In my career as a primary care doc, much of what I did, you did not need a physician's training to do.
Today, we're honoured to welcome Dr. Brian L. Strom, a true pioneer in the field of pharmacoepidemiology and one of the leading minds in biomedical research. As the inaugural Chancellor of Rutgers Biomedical and Health Sciences and Executive Vice President for Health Affairs at Rutgers University, Dr. Strom has redefined healthcare systems.
People do bad behavior, they get sick, they come in, they're treated for the sickness, they're sent back out where they do the bad behavior again. You're not focusing on keeping people healthy, you're focusing on treating them when they're sick. We don't need as many MRI machines, we don't need as many CT scans, we need people to think more.
With over 650 papers written, 15 books published, and more than 275 groundbreaking research projects under his leadership, his contributions have earned him international recognition, from shaping the future of healthcare to tackling global health challenges. Get ready for this extraordinary conversation.
Welcome to Success Story. I'm your host, Scott Clary. The Success Story podcast is part of the HubSpot podcast network. I am a huge fan of HubSpot because they support entrepreneurs. A lot of entrepreneurs, founders, executives listen to this show. And for entrepreneurs that are trying to build, I have a question for you. Does it feel like your teams are getting pulled in a million different directions when everyone's digging in on different projects with different platforms in different places? It can be tough to stay focused on a common goal, and that throws a wrench into things. That's why HubSpot brings everything your team needs into one easy to use and easy to love customer platform. With it, they have everything they need to scale the business at their fingertips. So your marketers can write blog posts in a snap with AI and build better leads with in-depth campaigns. Sales can build connections and close deals faster with tracking tools and real-time performance insights. Service can get a hand from AI-powered chatbots for better support and more 5-star reviews. And everyone can deliver killer results and grow revenue faster than ever before. Because when your teams work better, your business grows faster. Visit HubSpot.com to get started for free today. Brian, I'm super excited. I'm really glad you decided to join and come on. And this has been a long time in the making, actually. So I'm glad we finally got a chance to sit down and record together. But I want to kick this off. I want people to get to know you a little bit better. And I thought usually I ask this question at the end, but I thought it'd be a fun question to actually ask at the beginning. So if you could go back in time after your entire career, and you had an incredible career, and you could tell your younger self one piece of advice, what do you think that piece of advice would be?
Do what you enjoy. And it's actually the piece of advice I give to a lot of young people now. In medicine, people tend to sort of look at the next job and say, that's, the division chief above them, the department chair above them, whatever. That's where I need to go. That's where I need to go. And my advice to them and my advice to my young self would be the same. Get in touch with what you want and what you enjoy, and then do that, because that's what you're going to be good at. That's what you're going to enjoy most. It was only a few years ago that one of the young kids here at Rutgers made up a Wikipedia page for me. And it wasn't until they did that I saw that every position I've ever had, I have been founding or inaugural of whatever it is. I have never moved into an existing position. I've created them all along the way. And that would be my advice to people. Don't do what you think you should do. Do what you get in touch with, what you enjoy, and do what you want to do.
That's so fascinating. That's such an entrepreneurial personality that would do that. So you're telling me, so you over your whole career, you made the positions that you walked into.
Every one of them. Every one of them. And which I didn't realize until just a few years ago. And it's interesting, your comment about entrepreneurial. My father was a small businessman in New York. I had two brothers. He parenthetically, one older, one younger. He tried to get each of the three of us to join his business by overpaying us for a summer. We all hated it, and none of us went into it. But I grew up with the business sense, and now I often say I wish my father could see it now. And now I run a $2.3 billion business, and it's very entrepreneurial. When I walked in, this place was a disaster. We were very, very deep in the red. And now we're the only part of the university that's in the black. We're spinning off, large margins. Can't say profits, but contribution margins each year. Ours is a very entrepreneurial world in healthcare, and it's a Yeah, so it's interesting. I never thought of myself as an entrepreneur until you just asked about it.
No, you definitely are. I think that, listen, if somebody is entrepreneurial, and I actually love what you said about advice to your younger self and medical students and not just doing what they think they have to do next, because the lessons that we learn in one field parallel everything else in life. It's so interesting. So many people feel like they need to jump into entrepreneurship because it's cool, and they don't want to build within a company. They don't want to find ways to be innovative within a company. If you look at some of NVIDIA's employees, I mean, they've made a lot of money being very entrepreneurial, innovative within a company, and they didn't have to have the risk of starting their own thing or all the stress or all the struggle. They just built within a company. So I think that maybe not always having to follow the course that you think is laid out or the quote unquote right way. I think that's actually a really, really great lesson. I actually appreciate that a lot. When you were starting it, it's like, so maybe walk me through. So your background, you got paid to, your dad tried to bribe you to work in his family business. Yeah, let's just say, call a spade a spade.
Yes. Yes.
So what was the business? Why didn't you like it? Why was it not aligned? Where did you find yourself as a young Brian?
So he was a landlord in New York and running rent control buildings. And I just felt it was boring. It was uninteresting. It was, he did everything himself. He didn't have any employees and any assistants. It just wasn't the kind of world I wanted to live in. So,
but when you think about medicine, so there's so many pathways to medicine. How did you take your own advice and not follow the route that everyone else took?
I went to college in the 60s, late 60s. So it was Vietnam era. The buzzword of our generation was relevance. And so I started out in college majoring in math, majoring in physics, decided it wasn't relevant, wanted something more concrete and more human oriented, switched to psychology, though in those days it wasn't a rigorous science. It is now, but it wasn't that. And ultimately stumbled into a field, molecular biophysics and biochemistry, which in college where I was, we were one of the first. I was one of the first majors in that interdisciplinary field. But I stumbled into it as something that sort of covered, was biological, it was science, it was rigorous, it sort of covered the bases, and decided I wanted to go into medicine to apply science to be able to help people. But also I was interested in politics, and I was interested in policy from that point of view. And I knew from the beginning I wanted to do research that was policy related. So I sort of combined that in medicine, but went into medicine in an unusual, a little bit unusual way. When I started in medical school, you're taught, you use this drug for this purpose. Well, what's the basis of that? Well, you look at a textbook, it refers as it references. You look back, what does it refer to? Other textbooks. What does that refer to? Other textbooks. There was no basis for a lot of what medicine did. There still isn't. Medicine is as much an art as it is a science, and training in medicine is really an apprenticeship. If you've ever been to Colonial Williamsburg, medicine and pharmacy were the same profession in those days, where you worked in the pharmacy like a plumber, like a carpenter, for endless years being treated like dirt until you get your certification, and then you get advanced and you do that to other people. Well, pharmacy split from that and became a more academic field. Medicine still does internships and residencies and has very much the same kind of training, where you're learning from the professor rather than looking at what makes sense scientifically. And so I wanted to contribute to the science, but also science that was policy related. So so medical school, I spent the summer working at, I found a program in our school of public health. I found a faculty member in a medical school who was on the state legislature. I went to him and I said, what can I do research-wise that would help you policy-wise in terms of, and he had just passed a law called anti-substitution law. It was the first such law passed in the U.S. All 50 states have those now. It's the law that says if you prescribe a drug by brand name, the pharmacy has to dispense that brand name, not a generic equivalent. And he said, why don't you study the impact of that? which is what I did, and published a number of papers from it, got me interested in drugs, that is pharmaceuticals, to be clear, and again applying rigorous scientific methods to be able to study the effects of pharmaceuticals, and a field that ultimately became the sort of back into a field that we then called drug epidemiology. We ultimately renamed it pharmacoepidemiology because people's comment was, "Oh, drug epidemiology, you study heroin." There's no,
no, not exactly.
Yeah, prescription drugs, and sort of it was really sort of a scientific trying to use the methods of epidemiology, which no one knew what that was pre-pandemic. We used to walk around with T-shirts going, "No, I'm not a skin doctor." Now people know what epidemiology is. But using the methods of epidemiology to study the effects of drugs in large numbers of people, typically adverse reactions, because normally when a drug is approved for a market, you know it's effective in 500 to 3,000 patients it's studied, that's all it takes to do that. And what it means is if it causes rare adverse effects, even if it's very, very serious, the drug can be killing people, you won't know about it before it's marketed. And so not until it gets onto the market and you can study large numbers of people do you end up knowing what a drug's real effects are.
Well, I was going to say, that is just to hear that's very scary. But your goal in life was to obviously affect policy and not just affect policy, but I guess I want to understand when you look at that process as a young person going into medicine. I understand that you do want to affect policy for the right reasons, and you want to understand how some of the scientific choices or some of the drugs that are created are actually potentially interpreted or allowed through public policy and government and given out to the people. But when you see that process you just described, what's the red flag or what's the concern from your perspective that a young Brian was trying to change or trying to improve or trying to optimize? Because the way that you just mentioned that sounds very scary to the average person, saying only 3,000 people were tested and we only know the effects after it goes to market. What does this mean for me? And
it should be scary. And one of the lines I often use in press is all drugs are poisons. By definition, we are giving them to interfere with the body's normal system. They will be poisons. They will do harm. It's just they also do good. And so you make a clinical decision that the benefit is worth the harm. When you're looking at, parenthetically, natural products, herbals, whatever, they've never been proven to do good. So if they're doing harm, there's no positive trade-off. But in terms of pharmaceuticals, we know they will do a good. We don't know what their harms are when they're marketed. It's appropriate to be scary. What I've said to my patients through all the years, when they come to me with an ad for a new drug or whatever, doc, do you want to prescribe this to me? Is you see those drugs on TV, those are exactly the ones you don't want to use because we don't yet know what their effects are. And if it really was compelling that it was dramatically better than other things, I would have prescribed it to you already. Besides that, let's let the world experiment on other people and find out what the real effects of the drugs are. And so the answer is, as a young Brian, as a current Brian doing studies, we want to find out what the real effects of the drugs are, and the ones that are hurting more people than they're helping, remove them from the market. Most cases, that's not the case. There's a balance, but in order to make that balance as a patient, as a doctor, to make those trade-offs as regulators, you need to have the full data and the full understanding of what the effects of the products are. And we don't have that at the time of marketing. That's okay. It's not a flaw in the marketing process, because to go from 3,000 patients to 30,000 patients or 300,000 patients would delay access to good drugs and keep them off the market financially for a decade or 2 decades when people could benefit from them.
That makes sense. So it's always a risk, but so that there is always a risk. That's basically the net takeaway. And you just have to be aware that whatever you see on TV that, lists out 1,000 side effects after they play the commercial, maybe that's not something to jump into immediately, but the point is talk to your doctor. That's really the takeaway. But when you spoke about impacting policy, are there policies that have changed over your career? You've had a long career in this, that are a net positive or a net negative for that process? What is something that you were happy that changed? What is something that you aren't happy that changed? And then what is something that you still wish would change?
Interesting way to word it. So what are things that I'm happy changed? There's certainly a number of drugs. I'll give you two examples. One is a drug called Turtle, ketorolac. We studied the effects of it. It's an Advil-like drug. It almost came off the market. Didn't come off the market because of our studies showing its benefits. So we showed it that its relative safety relative to other products. An example of something which was wrong was a drug of the same class, Zomax, great marketing, the name of the drug. It's Zimiprec. It's another Advil-like drug. It was the first drug marketed as an analgesic. It's the first drug of the class marketed as an analgesic. As an analgesic, you would expect it might have a problem with serious allergic reactions. Ultimately, it did have a problem with serious allergic reactions. Got removed from the market. We did a study showing it was no different than other drugs used in that same way, but they had destroyed their market in the process. Another example, not drug-based, for 50 years, the American Heart Association and the American Dental Association recommended that people with heart valve abnormalities, which includes up to 10% of the population, if they're going to have dental work, have taken antibiotics before the dental work. So we were exposing 10% of the population to antibiotics twice a year, typically, with allergic reactions, with antibiotic resistance that caused, without any evidence that made sense. The evidence was animal data. It was data that you have blood, you have bacteria in your bloodstream when you have dental procedure, which you do, but you have bacteria in your bloodstream every time you have a bowel movement or brush your teeth. And was dental work any worse than any others? And in fact, ultimately, we did a study that showed it wasn't. And it got confirmed by people in the Netherlands, and all the recommendations changed. This was now, at this point, probably 20 years ago. All the recommendations of getting dental work every time that you have getting antibiotics anytime you have dental work have disappeared as part of that, based on our data. What do I wish would change that hasn't happened is about herbals.
Yeah, like a policy or something that you still want to affect.
Yeah, herbals would be
herbals.
Herbals, it would be a perfect example. So I'll give you one that did have, again, policy-wise, did have a good effect and didn't have a good effect. When the statins were coming off patent, the drug companies wanted to make them over the counter, in order to benefit from it coming off patent. I very deliberately wrote a letter to the editor of the New England Journal, carefully timed to get in the way of that happening, and it succeeded. I mean, they make no sense as an over-the-counter drug. You need to measure liver function. You need to measure cholesterol. It's not what an over-the-counter drug is about. Where the patient can judge the effects of the drug themselves. Contrary is the herbals. Herbals have never been proven to be shown to be effective for anything. They undoubtedly have harm, like any other chemical, and yet they're an extremely widely used product that people say, well, I take it, it makes me feel good. Yeah, well, they had nothing to do with the other. When do you take a medicine? You take a medicine when you're feeling worst. You take whatever it is, you feel better. Statisticians call it regression to the mean. The spontaneous return to normal will fool both you and the doctor into thinking it did some good. So it's that's how the story with herbals. Maybe some of them are effective. If that was the case, they would be drugs, not herbals, and we would know that. So the policy I wish would change is herbals should be regulated like drugs and required to have data on efficacy in order to be on the market.
Hey guys, Scott here. I just wanted to take a quick moment to say a heartfelt thanks to every single one of you. 6 years of this show, and it's really all because of you. Your listens, your support, your shares, it's what keeps this thing going. When I started, I had no idea how big this would get, how many lives we touch, the stories we share, the lessons that we learn together. It's truly humbling, and I believe that we're building something really special here, a community where no one has to reinvent the wheel. We're all in this together, learning and growing. And here's my ask. If you love this show, if it's made a difference for you, please share it with somebody who needs it. Tell a friend, post on social, whatever works. It's the best way to keep this thing going strong, bring on even better guests, and share more life-changing wisdom. And you can find us on all the spots. So you can go to successstorypodcast.com if you like listening to podcasts. If you like video, you can go to YouTube. It's youtube.com/c/Scott D. Clary, or the newsletter.scottdclary.com. Just spread the word. I'm eternally grateful for each and every one of you. Let's keep learning, let's keep growing, and let's keep making this world a little bit better together. All right, let's get back to the show. It actually seems, just very, very anecdotally, without the data to back it up, just through casual conversations, it seems like more people are trying herbals and Eastern medicine and all of these things that don't seem to be Western. And it's so interesting because I think there's cultures that seem to default to Eastern medicine or herbal medicine. I mean, I'll give you an example. Growing up, it was just regular drugs. I don't even know how else to describe it. It's like Western medicine and doctors and prescriptions and antibiotics and anything else. And then, so my better half, she's a couple different things, but her mother is Jewish, Israeli, and her dad is Russian, and she has tried so many different herbal things to get better. And when she's sick, the default is herbal this or herbal that, or try that. And there was like a Chinese doctor that she went to go see one time. I'm like, I don't understand any of this. Isn't from my world or what I knew growing up. So I feel like, and maybe just because I have proximity to it, but I also hear it in conversations, not a complete lack of trust in Western medicine, but some lack of trust in Western medicine. And I'm so curious why you think that's happening. And if I'm incorrect in that assumption, you could tell me that too. But I felt that in conversations.
I think you are correct in that assumption. Widely used and the herbals non-typical treatment isn't trusted. Are taken widely, and people instead take herbals and other things. And it does come a lot from lack of trust. Part of it is that given where healthcare has come and now it has evolved, physicians don't spend much time with patients. And as healthcare has more and more become a business, rather than sort of the solo practitioner doctor who comes to your house and whatever, you know, trust people as much. Now, again, if you talk to most patients, they'll all say, healthcare is terrible, except my doctor, he's great. And you know, people who have a primary care doctor, and I'm biased, I'm a primary care doctor, but people who have a primary care doctor typically will trust their primary care doctor. But more and more as medicine has become corporate, and as healthcare has become much more expensive, and as it become corporate, the times docs spend with patients is less and less. More of that is in front of a computer screen. And so the doctor's interacting with the computer rather than the patient. There's much less trust. And part of what alternative healthcare providers do is they spend more time with patients, in part because they're cheaper. So if you're going to make X number of dollars per hour, that whatever that clinical specialty is, if you're a surgeon, they want you in the operating room. If you're an anesthesiologist, they want you in the operating room giving anesthesia, not spending a lot of time talking to patients. And I think it has definitely hurt the trust of medicine. I think the other thing that has hurt, ironically, was years ago when the people came out with the 80-hour week, which probably doesn't mean anything to you, but the expanding to your audience. There were people who clearly were hurt and they hit the press because the doctors taking care of them were too tired. And so they put in place a rule for residency. We talked before about, treating your trainees like dirt as, endless slaves as residents, that you're not allowed to work more than 80 hours a week. Now, where the word resident comes from is they lived in the hospital. They were resident in the hospital. They were also called house staff because, again, they were in the house, in the hospital, accordingly. It was a commitment to your patient that was inherent in becoming a physician, that the nature of professional ethics was your patient comes first. And you stay in the hospital until your patient's feeling well. You do whatever's needed. The 80-hour week, the rule imposed because of fear that people were too tired, made doctors into shift workers. That at the end of your 80 hours, you have to leave, or the program is penalized in accreditation. So it's changed the character of medicine and our trainees completely with that. And I think there's a big loss. The big loss to physicians in terms of self-worth, but it's also a big loss in terms of patient care. But I think the corporatization of medicine has been a big part of it as well.
Do you feel like there's not an easy, but even any solution to that? Because I mean, that's not a great path that everybody's going down if they don't trust. And now you have this profit machine that, not just profit machine, you have, okay, respecting the wellness, physical, mental of the residents. I understand where that comes into play. But when you're talking about surgeons are in the operating room, anesthesiologists are in the operating room, there's a dollar value attached to every hour of a medical professional. There's this industrial complex that's driving this behavior. It's very hard to beat an industrial complex. So how do you create trust or space for medical practitioners, medical providers to have that time with the patient so they can restore the trust? That seems to be the X factor that has to be solved for.
It certainly is one issue, no question. I think one way is we need to make better use of other professionals. You don't need a doctor to do everything. So in my career as a primary care doc, much of what I did, you did not need a physician's training to do. Why did I do it? Because physicians could bill for it. What we now know, nurse practitioners, physician's assistants can often do it better and cheaper, and more routine tasks. And so and one of the advantages we have in Rutgers Health is all of those schools are under us under one roof. So if we need more nurse practitioners, we train them. If we need more PAs, we train them. And as the world moves to more population health going forward, and we move away from fee for service accordingly, because we're bankrupting the country in healthcare and yet don't have good outcomes. One of the solutions is we need to think more population based. And we need to make better use of other professionals who can actually do a better and cheaper job of it and save the physicians who are the most expensive for the things that you really need the physician's time for. And it's behavioral health has sort of done this using more time from psychologists and social workers and saving the physicians to write the prescriptions. In which case, it's not as satisfying to the physicians that they don't have the relationships with the patients. But, there's no one silver bullet here, but I think healthcare has become too much of a big corporate entity, focusing not on health, but it's really become sick care, not healthcare. It's really been people do bad behavior, they get sick, they come in, they're treated for the sickness, they're sent back out where they do the bad behavior again, whether it's smoking or drinking or whatever it is that they're doing too much of. You're not focusing on keeping people healthy, you're focusing on only treating them when they're sick, and that's because the current incentive system, that's what it pays for. Mm-hmm. That's what is changing as we move more to population health. Because we're bankrupting the country. We're approaching 20% of the gross national product, and yet we have bad outcomes. The countries that spend half as much as we have better clinical outcomes than we do, because we focus, we don't need as many MRI machines. We don't need as many CT scans. We don't need as much surgery. We don't need as much testing. We need people to think more. But the healthcare system classically doesn't pay people to think, it pays people to do. Surgeons are paid a lot. Primary care docs are paid much more. Pediatricians, neurologists, and psychiatrists are all paid much less than surgeons or other higher paid specialties. And we're in this cycle where if you want to maintain salaries, income, we need them to be spending all the time in the operating room and spending less time with patients going forward. So it's not one solution. I think the closest to one solution is really population health. It's really sort of moving to a per patient per month basis for reimbursement, where suddenly the risk of the providers, instead of being paid to do too much, You're taking the risk a patient gets sick.
Yeah, I understand. So now the incentives are aligned. Yeah.
But now the incentives are aligned in the wrong direction. Now the incentives are aligned to do too little. If you pay per month, it also changes the character, because individual docs can't, or even individual hospitals can't possibly afford that. One transplant patient would bankrupt you. So the docs come together, the hospitals come together, everything is all coming together, and that's what is happening in healthcare is the consolidation. Accordingly, in order to deal with that, you also, in order to prevent undertreatment, you need a huge data infrastructure. You need to be able to say, has everyone who's gotten the COVID vaccine gotten their COVID vaccine? Is everyone who has a high blood pressure, are they getting treated? Have they had high cholesterol, are they being treated? You need a huge data infrastructure to do that. And again, that requires a mass, a scale, to be able to put that together and afford to do that. And so what you're seeing across the country is this enormous consolidation as we move. We're in this funny in between now, moving from a fee-for-service system to a population system. And the health systems have a very hard time in different speeds in different localities. If you move too slowly, you'll go bankrupt. If you move too fast, you'll go bankrupt. Because right now, in many places, reimbursement is still primarily fee-for-service. So if you move too much toward prevention, you keep people out of the hospitals go bankrupt. But we don't need anywhere near the number of hospitals we have if we actually focused on keeping people healthy, rather than waiting for them to get sick and treating them when they get sick. So twisted incentive system.
So, I mean, maybe use Rutgers as an example. What are you doing to, when you talk about keeping people healthy? Yes, agreed. I've never gotten workout advice or nutrition advice from my doctor ever. And I'm not even American, I'm Canadian. So already I don't have to worry about paying for too much compared to coming down here. And I've actually found that, ironically, for the past year, I've paid more in insurance than I've ever billed. So like, it seems like I could just pay every time I go into the doctor and I'd still spend less money. I think I spent about 12 grand in insurance over the last calendar year. I did not have, I'm 34, I did not have 12 grand worth of things happen to me, God forbid, if we had a pregnancy, God willing, that'll happen very soon. Maybe there's a couple points in my life. Or if I get hit by a car, again, God forbid. But anyways, the point is, it's a very interesting system and it doesn't quite make a lot of sense. And it's so funny because even when I speak to my friends down here, they also don't understand it, even though they've been American their whole lives. They still get confused by the whole insurance system. But that's besides the point. In any system I've been a part of, there's never really been a focus on prevention or wellness. So at Rutgers, I was bringing back to my question, what are you doing to sort of prime doctors for this concept of wellness, prevention, focusing on true health, not just fixing sickness as like sickness is like a lagging indicator at the end of the day of what a doctor should be doing.
Absolutely. So let me give a few partial answers to that, because we certainly haven't solved the problem. So one is, I've been here now 11 years. When I walked in, New Jersey was all filled with onesies and twosies. The docs were all separate. The hospitals were all separate. In the interim 11 years, there's been enormous consolidation. In our part of Rutgers Health, I walked in, we had two separate nursing schools. We have two separate medical schools. We're now merging the two medical schools, bringing scale and in terms of bringing them. You don't need to duplicate everything everywhere. Mm-hmm. We're training more physicians assistants. We're training more nurse practitioners. We're focusing a lot more on the well-being of the docs also as part of that. But they're still trained as physicians. Their job is to treat people who are sick. We don't necessarily need one of each separately in New Brunswick and separately in Newark. If we can hire one person, because it's one school, who practices half-time in one and half-time in the other, treating people with the less common diseases between them. And so we're combining, we're bringing things to scale. But the other is, as we're merging the medical school, we're developing the two medical schools now. Robert Johnson Medical School in New Brunswick and New Jersey Medical School in Newark. We're merging them into the Rutgers School of Medicine. we are choosing as a theme for the entire school health equity. So this will be, when it's accredited in a couple of years, combining the schools, the second largest medical school in the country. And the entire focus is going to be on health equity, because we're dealing with populations in Newark, New Brunswick. We're with the people who get sick. They're not and have the biggest problems, who need the health issues. They're not people like you and me who are going to be exercising on our own. And I assume you don't smoke. I don't.
No.
But to take care of you. The people who suffer the most are the underprivileged, who are barely making it. And how do you? And they're the ones who are more likely to be hit by a car or shot or otherwise. But they're also the ones who have high cholesterols that nobody picked up, or high blood pressures that nobody picked up. So we are running. The simple thing is we do things like having our medical students and PA students and other nursing students and others, so they learn in the process, go out and screen populations, run campaigns in the populations in the community. Have your blood pressure checked. It's very easy to teach somebody to measure blood pressure. If the blood pressure is elevated, you then refer them for care. The students are learning prevention, and at the same time, the patients are getting intervened on to the degree they need it. From a medical school point of view, our plan is the entire medical school, new medical school, a merger of the two old medical schools, is going to focus on health equity as a theme. So everyone from top to bottom is going to get the medical students, the secretaries and the clerks who see patients. We want them to be treating patients right, whether the patients are underprivileged or not. They shouldn't be treated any differently accordingly. And just have a general, but also staffing appropriately. So you don't need a physician to do a non-physician's work as part of that. So this is a process, an experiment. Again, we will be the first medical school in the country to do anything like this. And as the second biggest medical school in the country, hopefully a model that others can copy from that, because health equity is such a focus. New Jersey is perhaps the one or two most diverse states in the country. We have 20% of the people in the state are foreign born, and a lot from South Asia, a lot from Latin America. There's a huge population from Oaxaca, Mexico, here in New Brunswick. Huge populations from Brazil and other countries in Newark. Huge African American populations in across the state. We are a very wealthy state, but also a very underprivileged state. And the other piece of that is wanting to generate the scholarship money to be able to support. Right now, somebody who comes from one of those backgrounds, no matter how poor they, and no matter how motivated they are, no matter how smart they are, can't afford to go to medical school. Our medical students graduate with a debt of $200,000. We have students who have debt of $400,000. You don't attract people into medicine who come from poor backgrounds if that's the case. And so they won't go back into those communities if that's not the backgrounds they come from. They're also less likely to go into lower paid specialties. They're going to want to become surgeons or otherwise, so they make more money. And they're also less likely to stay in New Jersey, which is an expensive state to live in. So wanting to mobilize the resources to be able to attract people, students from those populations is part of what we want to do. Wanting to have the entire school going forward, focusing on health equity as a focus. And another different example, we have one of the things Rutgers has is lots of students. We have 70,000 students, and we have a program where we have our undergrads get very involved in service learning across the state.
What's that? Yeah.
Where as a student, you're doing a course which is really providing service. So the example from a Rutgers health point of view, we have students, and we've had hundreds and hundreds who have applied to us now. So far, we've only been able to do it with about 40 from a financial point of view. Where the students mostly come from New Jersey, and some of the undergrads especially come from poorer areas, where as a summer job, that they'll get course credit and they'll get paid to go back to their community and screen for blood pressure, screen for diabetes, So you're educating the students, you're educating the parents. In the meantime, you're educating the community. Students get credit for it, as well as getting paid for it. Again, service learning, so that it's helping the community while at the same time they're doing it. And one of the things I'd love to do, we haven't worked this out yet, is randomly assign the different counties in New Jersey so that students in different counties would do different interventions. They'd go back home over the summer, and one county would focus on stop smoking. One county would focus on treat cholesterol. One would focus on treat hypertension. And then you'd have easy metrics. You've randomly assigned them across the different counties. All of them should benefit. But you look at, has County X's smoking improved more than County Y, where County Y's blood pressure has improved more than County X. And so we could study the actual clinical benefit, health benefit of this kind of intervention. But either way, it educates a large number of students, and students who hopefully disproportionately will go back into those communities.
I just want to take a second to thank the sponsor of today's episode, HubSpot. Now, HubSpot has an incredible podcast network. Success Story is part of it. And if you like Success Story, you're going to love other podcasts in their network. One of my favorites is iDigress. It's hosted by Troy Sandage. What Troy does exceptionally well is in under 30 minutes, he helps eliminate complexity, complications, confusion in your business. He talks about frameworks, strategies that really work to help you achieve scalable and sustainable success. So you need to go listen to iDigress, one of the most useful podcasts for entrepreneurs and founders, part of the HubSpot podcast network, wherever you get your podcasts. I love that. I think that's very smart. I didn't realize that common sense isn't common. And it seems like that's such a smart program, but I didn't realize that and what Rutgers is doing is that novel and no one else is doing it. Because if I just objectively take a step back and look at like a problem that I would see, so a lot of health problems are disproportionately affecting a different socioeconomic class of individuals. And then it almost turns into this negative flywheel, because now you have this class that's overburdening the local healthcare system, which already doesn't have the resources to deal with it, which is then going to cause even more issues for that particular class or that segment of the population. And it just seems like there's no positive outcome in this scenario. And this is probably how the U.S. is literally right now in 2024. This is how it is.
That's exactly correct. There was a great description. We refer to it as the social determinants of health. And the social determinants of health are probably much more important than anything we do clinically. And so by trying to intervene, one of our hospitals in Newark has just built housing for some of its poor. It's a state hospital. It's the only state hospital. It just built the housing for some of its poor patients, where poor and sick patients, they have a nurse who lives in the housing. The people don't have to go to the emergency room; they can just go to the nurse. But instead of being homeless, they're living in nice housing. So intervening on the social determinants of health and recognizing the importance of the social determinants of health is a key part of what we want to do in the new medical school going forward as we focus on health equity. That it's not just the highest tech care and the most expensive care, but it's really, if you want to have intervention that affects larger number of people, you need to affect them where they live and intervene on things. And again, it's often not the doc. The doc's time is too expensive. They're too well trained. It's not an efficient way of doing it. But rather, we should use things like community health workers who we hire from the community, train them, they go back into the community in order to try to intervene on some of these issues. COVID brought this all home so loud and clear, because it was the underprivileged communities that were suffering the most, dying the most, and yet weren't getting vaccinated because they didn't trust healthcare. And
that's such a sick, like twisted truth. Like, so they're dying them because you would look and you'd see the charts and the graphs, and just lower socioeconomic populations, they were just getting demolished by COVID. But I didn't realize that they also didn't want to get vaccinated because of lack of trust.
Exactly. They did.
So again, it's a self-fulfilling prophecy to a degree.
100%. And so in Newark, for example, we tried the dean of the medical school in Newark is African American. He's been there forever. He's got close ties in all the churches throughout the city. Using him and some of our senior African American faculty to go out into the community to try to educate the community. I gave a podcast with the mayor. Again, talking about COVID, talking about the vaccine and the importance of vaccine, trying to educate the community, who immediately resisted it. They immediately didn't want to do it because of lack of trust. And of course, our political environment didn't help that. The national political environment not New Jersey's. But our hardest hit communities are the ones that suffer most. And our focus we teach pedagogically about social determinants of health, but we want our new medical school to have that as, again, health equity and the importance of social determinants of health running from top to bottom, be the focus of the schools.
One thing that I thought was very interesting when we were prepping, I was looking at a couple different things to speak to you about. And one thing that came up was research priorities, because this is probably what you deal with every single day. So you have health challenges facing New Jersey, you have health challenges facing all of the US, right? But you have to figure out what areas to prioritize. But there's influence, and there's money, and there's people that want some things studied, and there's people that don't care about other things. So how do you balance all the influence, all the initiatives? I mean, maybe even like lay it out. Who does influence what you research and what you don't research, if it's not just you and your team?
Yeah. So directly, it's not me and my team, because we're an academic center. Faculty have the freedom to do to study what they want. So part of the influence is funding, NIH decides its priorities and so on. But the biggest way we influence it is who we recruit and who we hire. And recruiting people who see this as a priority. We have a faculty member, for example, who's a superstar, who's very interested in community-oriented research. In COVID, she was spending her time in community-engaged research, trying to say, how do we get the community more engaged? How do we get them wanting to get vaccinated, wanting to be treated properly? And by recruiting the correct people, you change the focus. Now, again, the school will never be prestigious if it's also not doing the high-tech stuff and the transplant stuff as well. But by making sure we recruit people who are have a focus on social determinants of health. And one of the things that was striking coming here, when I did my first strategic plan, now I've been here 11 years. First strategic plan sort of 10 years ago, 9 to 10 years ago. 50% of our faculty had community engagement as their primary focus. Striking that there was that high, again, with the State University of New Jersey, and our faculty really care about this kind of thing. And yet not many of them were researchers doing research in it. They were clinicians or otherwise. So another way to deal with that is to take some of these people who are really talented and really care about this and train them. So I'll give you an anecdotal example. One of my mentees now came from a very poor background in South Jersey, Pell Grant, drugs, alcohol in his family. Thought he was going to be a professional baseball player, but in high school injured his arm. Didn't realize he was a pitcher. Didn't realize it could be repaired. Depressed, dropped out of high school. They got into a lot of trouble with the law in the meantime. And New Jersey, very much to its credit, this is long before I was here and involved, obviously not my credit, and said to him, you can go through the juvenile delinquent program, or you can join this 6-month behavioral change program. He did, and it was a total change of his life. He went back to high school, did really well, went to community college, did so well that Cornell gave him full scholarship.
Wow.
For the last 2 years at Cornell. Went to medical school after that, became a trauma surgeon, was a star trauma surgeon and faculty member with us, 99% clinical. And then his father, who was a contractor, fell off a roof and broke his neck.
Jeez.
And he realized, people asked him for clinical advice, and he realized with all of his clinical skills, he couldn't prevent that, and that prevention was more powerful. So on the side, he ended up going to our school of public health and getting a master of public health, and then decided public health focuses on interpreting research from a policy point of view. He wanted to do the research. Instead, people pointed him, Brian, if you want his mentor, his trauma surgery mentor, said, if you want to learn to do research, talk to Brian. Referred him to me. He has since he's trained to do research. He's gotten multiple NIH grants, but he cares enormously about underprivileged populations and changing things. So we can direct people's research through training. If they care correctly, we can direct research through who we recruit into the field. we can't tell them what to do because of academic freedom. So,
do you not get a lot of pressure from pharmaceutical companies as well to do research on certain drugs? And how do you balance that out when a huge pharmaceutical company is asking you to do research because they're trying to get to an end result versus you as an institution wanting to make sure that the research is independent and sound?
Yeah, do we get pressure to do kinds of research? Absolutely, and we're happy to do them as long as we have control and independence. Exactly what you're talking about. We will never accept a grant without the ability to freely publish it, regardless of the result. So if they come to us to do a study, they are taking the risk that no matter what the result is, it's going to get public, because it's completely true.
Does that like, I mean, without naming names, does that upset some of the people that come to you?
Oh yeah, they won't fund us. There's companies that won't fund us.
Really? Like names that people would know would not fund you because they're worried about, oh geez, that's not good.
But there are other organizations, contract research organizations, that they go to instead, where they can control the results. And there's certainly companies. I do a lot of consulting for drug companies myself, and as well. And they're and I always make clear to them up front: is this consulting or is this academic? If it's consulting, they can keep it private, but it can never be published. And often they come to me and so I give them advice or help them design a study or whatever, and they say, "Will you publish that?" And the answer is no, because you didn't take the risk up front of being transparent about it. So real academic freedom and transparency is critically important to all the major academic centers in the country, and is the difference between contract research organizations and academic centers. And then the net effect is there are companies that won't help us do the research, but what it means is when we publish it has more credibility.
And is that something that, I mean, if I'm an average American, I'm looking for a drug to solve X problem. Just last thought on this point. What are the things that I should think about or look into, or even ask my doctor, or even understand if my doctor is being incentivized to push me one way versus the other?
Compound question with...
It is a compound question. I know. I'm sorry.
No, but great set of questions. To start with your last one, conflict of interest of your doctor is something absolutely to be sensitive to. And there are fields like orthopedic surgery or cardiology where there are more often conflicts because they've developed a new toy or a new hip or a new knee, and they only want to use theirs, and the hospital pays. You pay through your insurance, and that drives up costs. But there's clearly a conflict of interest, and no question there. So ask your doctor about the conflicts of interest if they're making recommendations like that. I think more broadly, physicians don't have the time or the expertise to read, to critically appraise the literature in detail. That's what, as a clinical epidemiologist, that's my specialty. But I think when you talk about prescription drugs, people should feel comfortable because you have FDA regulation. FDA goes through it in painstaking detail. It actually gets the actual data from the company and reanalyzes it. So if FDA gets a different answer than the company got, if the real data show this, the FDA regulation will, if it's FDA approved, it means it works. And it means it's as safe as we know, subject to the kind of things we talked about before in terms of limited sample size. If it's not FDA approved, like herbals, going back to that conversation before, like herbals and so on, then it's caveat emptor. You cannot know, and the doctor's not going to know, and nobody's going to know because science doesn't know in most cases because the studies haven't been done. And so it's we have a system of a learned intermediary. That's what the lawyers call it. Where the patient goes to a doctor, if somebody has an adverse reaction, they typically don't sue the doc. They sue the company, which is a deeper cut. But it's why the company, you talked about the ads with all those adverse reactions. All those adverse reactions are basically the company's legal defense. Well, I told them. And it was in my advertisement, so the patient should have read it. But we really have a learned intermediary process where the companies provide the information to the docs make the judgments for the patients, and the docs should have the ideally the expertise to do it. But that's where FDA comes in. But it goes back to my comment about why statins are not an over-the-counter drug, because they're both both to measure their efficacy and their safety, and their adverse reactions. You need physician expertise and access to laboratories to be able to do it.
When you looked at merging some of the two largest medical institutions, I mean, this is very difficult to do. It was very complex. Talk to me about some lessons learned, maybe even from like a leadership perspective, that you had to figure out when you're doing this merger.
Yeah. So and again, to clarify, they weren't the largest to begin with, but they will be the largest once merged. Yeah, it's been a real education. As people have said to me when I came from Pennsylvania, New Jersey is not one state; it's three. Yes, it's small, but South Jersey, Central Jersey, North Jersey are very different. They're rivals in different cultures. And here I proposed, now happening, merging medical school from the central part of the state and the northern part of the state, merging together. Those two together, by the way, have 75% of the population of the state. But it became a little bit of a political football. It became a lot of rivalries. It's like having two children, and each thinks the other is the favorite. And why are you doing this? You're doing it to benefit them. The people in Newark, because the university is based in New Brunswick, the people in Newark were afraid we were abandoning Newark. In the process, that it was New Brunswick taking over Newark, and which is anything but. It's actually had the opposite effect. But as much as I tried including people and talking to people and talking to faculty and so on, I clearly didn't do enough because it generated a backlash of people opposing it. Now I did a much better job of educating our governing board because they unanimously voted for it. Now that our two deans are working on the merger, they've had very, very wide engagement. Hundreds of faculty, students, staff are involved, and the opposition has melted away. And so it's there was a lot of fear of we're going to abandon so-and-so. My comp plan is going to change to their comp plan. My salary is going to go down. I mean, there was enormous misinformation out there. And as much as I did spend time trying to address it, in retrospect, it obviously wasn't enough. But now that we're in that process and the two deans are in the process of doing it, the faculties in the two schools didn't even know each other. They didn't know each other's curriculum. They didn't know each other's processes. They're both training docs. They got together and they said, "Oh, you're much more similar to us than we thought." Yeah, you're both training physicians.
I have to take a second and thank the sponsor of today's podcast, LinkedIn. Now, when you're hiring for your small business, you want to find quality professionals that are right for the role. And that's why you have to check out LinkedIn Jobs. LinkedIn Jobs isn't just a job board. It helps you hire professionals you can't find anywhere else, even those who aren't actively searching for a new job, but might be open to the perfect role. And did you know that in a given month, over 70% of LinkedIn users don't visit other leading job sites? So if you're not looking on LinkedIn, you're looking in the wrong place. What really amazed me was how quickly I found qualified candidates on LinkedIn. 86% of small businesses get a qualified candidate within 24 hours. It's like hiring professionals like a professional on LinkedIn. As small business owners, we're always juggling multiple responsibilities. LinkedIn understands this and constantly finds ways to make the hiring process easier. They've even launched a feature that helps you write job descriptions, making the process even quicker. And it's really no wonder why 2.5 million small businesses use LinkedIn for hiring. I can't recommend it enough for finding top-notch professionals who could take your business to the next level. Post your job for free at linkedin.com/excellence. That's linkedin.com/excellence to post your job for free. Terms and conditions apply. It's ironic how this is a little micro example of the world at large, but I'll leave that. I'll leave that be. Yeah.
Yeah, and it's but with a lot of resistance that met a lot of resistance in the process, which again has since melted away. And the irony with the concern about the abandoning Newark, the wrong concern about abandoning Newark, we're in the process of building a big new research building in New Brunswick, which will have a lot of space for laboratories and space for spin-off companies as well, incubator space for companies as a part of it. So the labs of the medical school, which will also be moving into New Brunswick, can spin off companies accordingly. The building in The medical school building in Newark is old and dilapidated. We had renovation plans for that too, but it's easier to build a new building, and the governor was more interested in that than an old building, than renovating an old building. But part of what we've had found out since in planning for the accreditation of the new combined medical school is the students on the two campuses need a comparable experience. And so it accelerated the renovation in Newark. So rather than us abandoning Newark, the fact that we're combining the two schools has actually led to it's helping Newark and accelerating that renovation. So and we're certainly not abandoning it. The best medical schools give students an experience in community hospital, private hospitals, and safety net hospitals. We had them split, and it makes much more sense from a student point of view to have both options in the same school, so people can be educated in all of them. That the expertise in the two schools is different. The scale of the two schools, again, they're both sort of comparable, but together we will have a scale. Both of our cities are not that big to be able to have enough people with uncommon diseases to keep a physician busy. Having one physician who can practice in both places makes much more sense. Without that, people had to go to New York or Philadelphia for care of rare conditions. People who socioeconomically can afford that, it's inconvenient, but they can do it. But the poor can't. And so again, from a health equity point of view, it means we can better meet the needs of the community because we can meet the needs in New Jersey, which parenthetically ends up being much cheaper also because it's not out-of-network insurance, and meet the needs of the local communities and meet them locally. My cancer center director likes to say cancer doesn't travel well. If you're in chemotherapy or radiation therapy where you're going every day for treatment, you don't want to be going back and forth across the river and across bridges to be able to get that kind of care. Delivering it locally is much better for the people of the state of New Jersey. So it's better for education. It gives a larger scale for research. Most of all, it's better for the people of the state because we can treat uncommon diseases that people would have had to go to New York or Philadelphia to get that treatment, which again is either inconvenient or poor people can't.
So I mean, really, what I'm hearing is the future of healthcare, and this is what you're doing in New Jersey, but this can be a model that you can replicate in other states. You can replicate it anywhere, really. It's all about interdisciplinary collaboration. That's really it, and it's so strange that that's not the case right now.
Yeah, interdisciplinary and interprofessional. So certainly it's not the case now. You got the surgeons, you got the internists, you got the cardiologists, you've got each is a separate silo because each has separate regulation and separate licensing responsibilities. And it doesn't even make rational sense. A cardiologist, that's a subspecialty of internal medicine. Cardiac surgery is a subspecialty of surgery. Cardiologist has a lot more in common with a cardiac surgeon than they do with an endocrinologist who's treating thyroid problems or whatever, but that's not the way medicine is organized. And historically, it's not been interprofessional, where you don't reach to nurses and physician's assistants and so on to give care because it's all been physician care only. And so the consolidation gives the opportunity to be able to do that and to be able to pay more attention in the process to health equity. People like physician's assistants, nurse practitioners are much better at focusing on health equity, spending more time with patients, spending on health and staying healthy, giving counseling to people accordingly. Physicians are too busy to be able to do that. You need a system that really combines them all. And really, we have the advantage of Rutgers, and I said this publicly many times, developing the healthcare system of the future because it's all under one roof. Mm-hmm. We produce the physicians, we produce the nurses, we produce the physician's assistants, we produce the physical therapists, the occupational therapists, whatever it is. Everything, and we can change the numbers as need be in order to do it. And it's a grand experiment to try to help improve a very inefficient and not very effective U.S. healthcare system using New Jersey as the laboratory.
I was going to say, it is an experiment, but just to echo your point, I don't think the existing is working very well. I don't think it's working very well. If you look at other countries, nobody looks at the U.S. as the epitome of healthcare.
And we know that. And health statistics, we spend much more money and we have worse outcomes.
Yeah.
A part of it, again, how many people show up at our safety net hospital in Newark when the first care they get when they're pregnant is showing up in the emergency room in labor. And think about the problems in the offspring and the costs that involved and the trouble that could have been prevented if they had been treated beforehand and seen beforehand. But instead, we're focusing on the transplants and the high-end things, and we have to do that too. The U.S. is really good at that and spends too much of its money on that.
Yeah, but but you also have to take care of the rest of the population as well. That's also very important.
Ideally, keep them out of transplants. The point is they don't need kidney transplants if we treated their blood pressure right, and the kidneys never went bad to begin with.
It's very interesting, and I don't want to go down this rabbit hole, but it's very interesting how I find that out of all the topics that are discussed in the political arena, healthcare is not prominent. It's very interesting how that's never addressed, and it's just sad, I think, because it has to be. But it's good that you're addressing it other ways.
It had been in the past, and Obamacare was a major compromise, but a major advance toward that. And then prior president tried to undo that over and over and over again unsuccessfully. So it's sort of when one party can't undo it, and the other party has succeeded in going as far as what we really, my personal view, what we really should have is at least a public option. It maybe not worse to it. The most efficient healthcare in the U.S. by far, is Medicare for the elderly, where you don't have the huge bureaucracy. We spend 25% of our healthcare dollars on dealing with this huge bureaucracy. So if everybody was offered, even young people, were offered Medicare as an option, for example, it would make much more sense. But that's...
Well, I wish somebody would focus on it. That's the...
Yes.
Okay, so I want one thought on what you're excited about for the future of healthcare or medical research, and then also one thought that you're excited about on just the future of healthcare or medical care.
Interesting. So let me respond this way. My refrain since I've gotten here, the first and last slide of every talk I give, different pictures, but to build one of the best academic health centers in the country with an emphasis on one. And the tagline of the emphasis on one is integrating. One of the things I've done my entire career has been to take different fields. In my personal career, I bridge across multiple separate fields. One of the difficult decisions I had when I first arrived was which school do I take my tenure in, because there were multiple options. So I think the nature of healthcare is we need scale and we need teamwork and we need people be able to work together in a way that they don't now. They work in silos that don't focus on the patients. They focus on themselves and their professions rather than best servicing the patients. And I think we're building a model for that. And in the medical school, we'll be building a model, particularly one that focuses on health equity, trying to keep people healthy rather than just waiting for them to be sick. Research-wise, I think certainly figuring out how to do that is going to be a key question. I think completely different is what's the role of artificial intelligence in healthcare, where we talk about doctor-patient relationships. Computerization of electronic records has had many advantages, other disadvantages. One of the disadvantages has been getting in the way of doctor-patient relations. As we move to AI, how do we make sure there aren't mistakes made and people getting the wrong thing because of AI? And how do we make sure it doesn't get in the way of the doctor-patient relationship? Much of what, again, I'm a general internist. There's no data behind what I've about to say, but an anecdote that sort of rings very true. That as a general internist, 90%, 5% of your patients are going to die no matter what you do. 5% are going to get better no matter 5% you're going to change their course. The other 90% are going to get better no matter what you do. It's regression to the mean. That they come to you when they're worst. They're going to spontaneously get better. they feel better because of the physician laying on of hands, of the physician relationship, and having the time with the doc and interacting. How do you protect that in the face of scale, corporatization, and the need for efficiency? Those are major research questions in terms of how do you design a healthcare system that's optimal, and how does AI help that, or is AI going to help that? It's going to hurt that. If AI gets in the way of the physician-doctor provider, not just doctor relationship, then AI is going to be harmful. If AI allows you to be more flexible, more efficient. So, for example, we've developed now an AI program. When someone's hospitalized, you summarize the hospitalization, what's called a discharge summary. It takes a lot of work for the doctor to put that together. Everyone resents it, paid for it, but it's an appropriate part of important in care. We've now developed an AI program that will present to the doctor, based on scanning the electronic medical record, a discharge summary that summarizes it all. Doctor still has to read and edit it somewhat, but so far it looks like it's working really well. We'll save a ton of work and let people get much more efficient. That won't get in the way of the doctor-patient relationship. That'll save time. That reduces cost rather than cost. How do you use AI in order to be able to improve the efficiency of healthcare
and increase the time where you can have those human-to-human interactions, basically?
Absolutely.
What would be one piece of advice that you've received from one of your mentors or one of your peers over your career that's really influenced how you work?
Care about the patient first. The patient has to come first.
That's the theme.
Yeah. Healthcare is designed around the doc. Sometimes there's fights. Should it be designed around the nurse? Should it be around, it should be around the patient. It should be what makes most sense for patients. We are building a new cancer center where all in one building, a patient with cancer doesn't have to go one end of a complex for radiation therapy and a different end of the complex for chemotherapy, and a different end of the complex for blood testing. Those silos are how healthcare is now organized. And there are lots of different ways, even in our construction and our architecture, that we can change that by being more patient-centric.
I love that. We went into a lot. What do we not go into that is sort of on your mind right now? Something that you'd like to leave the audience with?
I'm not sure. We did cover a lot.
You don't need an answer, by the way, for this one. I'm just giving you the floor. There's no right answer for this. We went into a lot. I really appreciate it. I'm glad we sort of covered as a wide range. Chatting with you is fascinating. I'd probably talk to you for like hours, but I want to keep it within the confines of what we've spoken about today. A fun question that I thought of: if you look at historical medical figures that have innovative, that have changed the way that we do things, who is one that you most associate with? Who is one historical medical figure that you wish you could collaborate with them today?
Really interesting question. William Osler. And as a disciple, sort of, and I'll describe what I mean by that. Philip Tumblety at Hopkins Rutgers Medical School. They focused on the patient. They focused on clinical skills, not just technology. Tumblety was my advisor at Hopkins Medical School, and I have this talk that he gave, something in his books, on the wall, and I quote it on every graduation speech about the power of being a physician and the importance of being a physician, and the ability through your personality and the laying on of hands and having a conversation to make to cure people and to make the dying feel better as they die, and the enormous power in that. And yet Tumblety didn't even know how to read an EKG. He was the ultimate physician's physician. When you didn't know what was wrong, we had what we call Tumblety rounds. You presented the case to him. He'd go through a detailed discussion, some differential diagnosis of what may be wrong, what may be right, and why ultimately he thinks it's this disease. Someone was in the hospital for 2 weeks doing the testing, and it always proved him right.
That's so funny.
Clinically enormously skilled, not tied to just technology. We are. Don't get me wrong. Our modern medical technology is fantastic, but we sometimes lose sight of the personal aspects in the meantime.
I love that. Brian, I appreciate you a lot. If people want to learn more about what you're doing, connect with you, where do they go? I mean, you can send people anywhere. I'll put a whole bunch of links in the show notes as well, but where should people go to explore?
Yeah, so one is Rutgers Health. What we're doing in Rutgers Health websites is probably, and if people wanted to connect directly, I have a Chancellor email address. Let me. I don't know what it is offhand.
No, that's fine.
But and I can here it is. Chancellor at RBHS.Rutgers.edu. So it's Chancellor at RBHS, Rutgers Biomedical and Health Sciences. We've changed our name to Rutgers Health because it's a better name. But our legal name is still RBHS.Rutgers.edu. And it's a one of the sort of bottom line messages is that this is a very exciting time in medicine. It's a very exciting time in my life in terms of being able to I've always been a change agent. I came here knowing that and in fact, my job, the Chancellor job, was created when UMDNJ, University of Medicine and Dentistry of New Jersey, was merged into Rutgers. Every time the presidency of UMDNJ became available, I was asked to look at it, and I refused even to look. But when this job became available, merged into Rutgers, I saw the potential for the kind of change that I could drive on a statewide basis, and we're doing it. We got a long way to go, but it's just I'm sort of very proud of what we've been able to accomplish and what we will accomplish in the future.